So our learning objectives for today really are to identify some of the most important issues regarding safety that really commonly arise across professional social work practice settings. To talk about applying general strategies for safety and preparing for assessment and mindful practice, again in a variety of settings. And identify and apply specific techniques for safe interactions in a field placement. Again, we want to be able to provide some additional resources, which again, I'll mention your handouts, and support regarding strategies for safety in current and future social work practice settings. I think one thing that it's important to note is that we can't possibly cover it all today. We're here together for 2 hours. We know that social work crosses many practice arenas, and we wouldn't be able to cover it all. So our hope is really to provide you with some foundational and transferable concepts and tools, and then some examples of what comes up in practice situations via our guest speakers. So with that, I'm going to pass it off to my colleague, Eva Solomonson.
Okay, so I was thinking today about talking about safety, and I was thinking, you know, if we were all training to be welders, we would still be coming to a workshop on safety. So it's not anything but normal to be talking about how to be safe in our work environments, and that's kind of the way to be thinking about what we're talking about today. So coming from our National Professional Association, the whole idea and permission for thinking about safety is articulated as social workers have the right to work in safe environments and to advocate for safe working conditions, just like any other profession. Interestingly, in this statement on safety, the NASW continues by saying, social workers who report concerns regarding their personal safety or who request assistance in assuring their safety should not fear retaliation, blame, or questioning of their competency from their supervisors or colleagues. I think it's really interesting that that's included because I think it kind of tells a little bit about a special tendency that social workers sometimes have of thinking that we might devalue our own safety. So I want to just put that out there at the beginning, that we as professionals are supposed to be taking care of our own safety, and we should in no way think that we're any different from the welders or anybody else in terms of keeping ourselves safe in our work. So a couple of general things. I'm just going to give a couple of, show you a couple of slides that are hopefully going to just lay a bit of foundation for today. So first of all, as I was alluding, social workers do tend to underreport safety problems, and we're hoping to, from the beginning of your career, help you to avoid that tendency. Safe practice involves interactions not only with our colleagues, but also with our clients, and also with whoever it is in the environments that we're working in. And I also think it's really important to note that you guys are not just going to be frontline social workers, but probably a lot of you are also going to be supervisors, policymakers, and you want to be thinking about the importance of safety for yourself, for your clients, for your colleagues, and for those that you supervise. So one of the ways that we're conceptualizing safety today in this training is that there are really two overlapping components. So probably one of the first things you think about is your physical safety when you're going out into neighborhoods, when you're with clients who might be in heightened emotional states or unstable states, etc. But there's also the whole other realm of emotional safety. We all have the right to be respected in our work by our colleagues and by our clients, and to feel internally safe or emotionally safe. So we're going to have Miriam later is going to give an example in that particular realm. So another conceptualization that we're thinking about is that safety planning really is a continuous circle, before, during, and after kind of an experience. So in the before phase, we're thinking about, and we need to be thinking about, what are the things we need to do to prepare ourselves and to anticipate what kind of risks we might encounter in a normal circumstance with our clients. Then, while we're with our clients or in any kind of a situation for our work, we also need to think about what skills do we need in the minute and how do we bring those forth in the minute when something is unfolding. When we're recognizing that now is a time when I need to be doing something to make myself safe. So that's the during phase. And then this is the part we oftentimes forget, but the after phase. So if something happens, you're in a high-risk situation, you've resolved the situation, what are the things you need to be thinking about afterward to continue with this commitment to having safe practice? So I'm going to just talk a little bit about those three pieces. So in the prevention piece, I just wanted to note that the clients and the families that we encounter most of the time do not pose a risk or a safety risk for us. But there are certain environments or certain populations that we know are going to be a little bit more high risk. And some examples are there, like child welfare, adult protection, mental health, criminal justice, and domestic violence shelters. We just know that, and if those are the areas we're working with, we just need to be thinking about the special circumstances of those settings. Oftentimes, though, it's not the people that are the risk, sometimes it's the environment. So things that we want you to be expanding your thinking about are what are the neighborhoods that you're going to and what are the ways that you can keep yourself safe when you're moving from your car, from your agency to the car, or from your car to a client's home. Likewise, home visits. If you work in a medical setting, there's all kinds of things that you want to be vigilant about so that you stay safe in terms of disease prevention, et cetera, things that you should be trained in to work in those environments. And then, of course, weather. You could have a hurricane. You could have slippery, icy roads when you're doing home visits, that kind of thing. That all counts, too, for keeping yourself safe when you're doing your work. So for prevention, what should you know? And these are the kinds of things that you're going to want to think about in your own placement and have conversations in your own placements with your supervisors about what type of risk happens in this placement more commonly, and how great is the risk, and how do I figure out how great the risk is in a particular circumstance. Then you want to be thinking about and asking about, well, what are the specific policies and tools that are already in place in the agency that are meant to help me to keep myself safe, and how do I use those? And then finally, this is an area I think you really want to explore. What are your personal strengths and vulnerabilities regarding safety? So a strength might be that you're 6'2" and you're 250 pounds. That could be a real strength. Knowing techniques for keeping yourself safe, like de-escalation, self-defense, those kinds of things could keep you safe. Knowing how to handle medical supplies will keep you safe. Those are the kinds of personal things, but also vulnerabilities, like what are your thoughts about your own value out there and how important it is for you to put your own stuff first sometimes. That is, putting your safety up at least as important as the concerns for your clients. And there's many other aspects of knowing yourself that can come into how you think about safety. Then during the actual incident, if something is a high-risk situation, some of the strategies that you might think about a variety. These are just some examples. But de-escalation or nonviolent self-defense. You might want to be thinking about what's my exit strategy. So sometimes the important thing is to just get out. If you're in a home visit that's not feeling good, you might need to just get out. Or if you're in an office situation and it's not feeling good, you might need to just step out. Or how do you know when it's time to call a colleague in to help you? There's lots of times in my practice where I need to call somebody else in to help me move through an unsafe situation. And then finally, don't forget there's all kinds of cool technology. You probably know way more than I do already about it, but Things like little panic buttons in offices that will call someone in to help you if something is kind of getting heated up. So know what those things are. And then finally, after. So after you've managed the situation, super important to report. And to report it to your supervisor, maybe to report it to your colleagues so that they know these are the kinds of things that could happen to any one of the colleagues, and to be thinking about how are you going to mitigate those risks in the future. You also need to evaluate what strategies you actually used. Did they work? Are they still viable and useful strategies in the environments where you're at? And if not, how do you need to tweak them? And how do you need to keep tweaking those strategies so that you continue to feel safe in your particular circumstances? And then finally, you need to continue to monitor your own habits. Because I'll tell you one thing that does happen among social workers somewhat commonly is that as we move along doing our work, we oftentimes start to get a little lax in thinking about the importance of this, or we cut corners in terms of safety policies that are already in place. So I'm just going to encourage you to continuously monitor your own habits about how you keep this as a high priority. So I'm going to, before I go on to the next slide, I'm going to introduce my colleague Miriam, and she's going to talk about an example of a really important safety consideration that lands squarely in that emotional realm.
Hi, everybody. Thank you. There we go. I'm going to talk briefly to you about sexual harassment, what it is, why we should be thinking about it, and how it might show up in your field placement. So in terms of what it is, I want to recognize that many of you have had jobs and have probably gone through sexual harassment trainings. None of this or some of this information may not be new to you, and so just take it as a refresher if that's the case. And in terms of why we should be thinking about it, NASW, the National Association of Social Workers Committee on Women's Issue, has identified that sexual harassment is a major issue for women in the social work profession, and that as many as 60 to 90% of women in social work have experienced some sort of sexual harassment. I know there are people in this room that are not women, and that sexual harassment can happen regardless of gender. Okay. And I want to talk a little bit about what this could look like for you. So I have a couple of scenarios. These are scenarios that field liaisons have written up that actually happened to students in the past few years that were discussed in seminars. So this first one, a student is completing her practicum in a small high school. She enjoyed integrating with all of the school staff. However, the school security officer has continued to ask her out on dates, and she doesn't want to date him. She's told him no and asked him to stop making this request and to stop sending her personal text messages, but he continues. She wants to have a good working relationship with this colleague as well as with all of the school staff, and for this reason, she's hesitant to complain or make a fuss. After several weeks, she asked her field faculty liaison what to do to best handle the situation. And the liaison directs her to the sexual harassment policy in the field manual. So all of you should be aware that in your field manual, which is on IPT, there is a sexual harassment policy. And the student discussed it with her field instructor, who addressed the issue internally. Agency policies related to sexual harassment were referenced, and the security officer was asked by school staff to change his behavior, which he did. Another one. A female student is placed in a shelter. As part of her responsibility, she takes drop-in clients to the shelter's clothing closet, which is located in a relatively isolated part of the agency's building. On the way to clothing closet, a client makes a sexually suggestive comments to the student, and at one point he reaches out to touch her inappropriately. She felt flustered and somewhat scared, but she quickly helped the client get his clothing items and return to a more public area of the agency. She was hesitant to talk about the incident because she felt vaguely embarrassed about it. She did eventually talk to her seminar class, and once again, went through the policy in our field manual and spoke with her field instructor who, was not aware of the risks of what was happening. And they changed their policy about students accompanying new clients to the closing closet. And so students would then carry walkie-talkies or be joined by a second person. The thing that sticks out to me to this and the last one are a couple of things. One is that we feel embarrassed to talk about it or to ask for help, that somehow this is something that we should not have happened to us or that just feels a little shameful for whatever reason. But the bigger message to me is that once we do talk about it, often these issues are relatively quickly and easily resolved. I think we have time for one more. This was a student who is in a county corrections setting, and as part of her work, she meets with adult clients on probation. One of her clients comments frequently that she's attractive and that he's interested in knowing her personally. She's asked the client to stop bringing this up, but he continues to do so. When she complained to a colleague at the setting, the colleague laughed and said, "This is just something you have to get used to when working with this population." And the student brought this to the field seminar and was encouraged to discuss it further with their field instructor. And the field instructor said, you know, this does happen so frequently that I sort of forget that it actually is an issue. This is like the policy, I think, that Eva talked about at the beginning, that somehow social workers feel like this is just to be expected, it's part of the job, or that if you can't handle it, you're somehow less competent. But the supervisor reviewed the county policies and offered guidance, including like a specific script that the student could use, words to talk to that client. And also offered that she could withdraw from that case, which eventually she chose to do. So I'm going to move on to our panel in just a minute, but I want to just sort of point out that what you're doing if and when you recognize sexual harassment as part of that intersection of physical and emotional safety, if you recognize it and act on it, what you're doing is agreeing to the premise that people have a right to work in a safe and respectful environment. Not only you, but your clients. You're modeling that for your clients, your colleagues, the community, that that is a basic right, that when people go to work, they should be not subject to harassment of any kind. So modeling that behavior and living as if that is the kind of world that we live in and want to live in. Okay. It's not actually Q&A, but I'm going to leave that up there so you can see the names. We have a distinguished panel of social workers. I'm going to introduce them to you, and then we're going to ask them some questions. Can you hear me all right? I can't tell. Okay, thank you. I'm going to ask some questions, and we'll sort of go down the row and have a little bit of a conversation. We are going to have some time for question and answer at the end, so I think, are we asking people to sort of hold questions until then? Right here we have Steve Collins, who is a social worker at Central High School in St. Paul. Can I also say was also my field instructor when I was in grad school. So those of you who sometimes hear stories in my seminar about some of my field placements may hear a story or two about Steve. All good. Next we have Amber Ross, who is a social worker at St. David's Center for Child and Family Development. She's going to talk a little bit about, so Steve is going to talk about the school setting. Amber's going to talk a little bit about community and home visit settings. She also has a lot of experience in residential treatment settings, so she may bring some of that in as well. And finally, Kayla Appleby, who is a social worker at Bethesda Hospital through Health East Care System. So we'll be talking about safety in medical settings. So the first question is, what are the top safety considerations in your specific setting? Each of you will have like 3 or 4 minutes to answer each question, and maybe we'll just go right down the line. Steve.
How does this work? Do we put these closer?
Yes, make sure you're just talking into it. It should be on.
Is it? Hello? Can we hold them?
Sure.
I feel like I'll hunch if I do this.
Absolutely.
So again, my name is Steve Collins. I've been a school social worker for 22 years. 14 at Central High School, I think. And so it's always been in the school settings, except for 1 year at outpatient mental health. In the school, all of you went to high school, so you'll remember this. And all my time has been in high schools, never with the little people. So all of my reference is all with older kids. When we talk about safety considerations, we talk a lot about de-escalation. A lot of times that role falls on the school social worker. So you have a kid that is very dysregulated. Oftentimes then that child will be placed in the social worker's office and they'll say, you calm them down, which is cool. That's what we're there to do. I mean, that's what our expertise is. But we will have some pretty volatile kids that will, there are times where you're worried when you're the only one in that office and you're between them and the door. That can be a pretty dicey situation. The other one is we do a number of home visits, but I'll leave that more to you. But we do a number of those where we'll go out because sometimes our families can't get into the school, so we'll be the ones to go out there and meet with the parents or guardians or whomever. We also do what we call a well child check. So if we have kids that we're worried about in terms of their own safety or safety from family members, we'll go out usually with a police officer now, which is something we didn't do as much in my younger years, which is a good thing. To have some of that backup. So we do those well child checks. And then the other top safety concern, I think, at least in the school setting, is Central has about 2,000 kids, and it's an urban, I mean, you know where that school is. It's just right up the road. And the ratio of social workers to kids is pretty outrageous. So the other big safety thing is just we get really tired and really burned out by the end of it. And I think I've thought more of that over the last 2 years of my career is the emotional safety. And it's not kind of the way you all describe it. It's more toward we take so much in and do so much there that I think at times we forget that we have to take care of ourselves on that or we're really no good to anybody else. So that's my other top safety thing.
Good afternoon. In my current role, I supervise foster care coordinators who are going out to visit foster care providers and the children in their home. I also supervise in-home therapists and mental health skills trainers. So the first thing that we're worried about when it comes to safety is just the community and the environment, because like it was pointed out earlier, oftentimes the neighborhood or the location where you're going to is going to be your top concern, followed by what's actually going on in the home, who's home, how is our child and parent acting, as well as what's the pet situation. Because a few people in this room know me, and you knew what my fear of pit bulls was like before exposure therapy. So that was a little bit of a thing. So if you've got animal issues, you've got allergies and whatnot, you have to pay attention to those environmental factors when you go in home, as well as some of the other issues such as bed bugs, the outbreak of lice among the children in the home, and whether or not you might transport that with you as you leave. The gifts that keep on giving, right? The other thing has to do with the volatility of the clients, but one of the other big things that comes with in-home work that you need to remember that I wish I knew ahead of time was your own personal car safety. Your car is now your office, and if you're transporting clients, you need to pay attention to that. So your prescriptions, the things that you've got in your car, the randomness that's going on in the dashboard, your kids' toys in the back seat, you have to pay attention to that because your car is now your office and you're transporting clients, and then you will ultimately be responsible. And if any of you have done in homework and you've transported clients, you've also had a couple of kiddos that, I don't know, maybe on the way to an appointment decide to bang on your window and threaten to jump out the car. So you kind of also want to be a little bit aware of how you might handle that situation, what the potential is of that child doing that. Those are the things that we consider. In my previous role as program director at Avanti Center for Girls, inpatient residential treatment center for adolescent females, and we specialized in treating girls who struggled with suicidal ideation and self-harm. So preventing those behaviors was our top concern, and that meant literally you had to pay attention to pens, anything metal and plastic. That was number one, and I learned that one the hard way my first day in therapy. I had a pen in my hand, and the girl grabbed it out of her hand and self-harmed in front of me. It's like, oh, that's why they only write with crayons until they're reach a higher safety level. And I had to shift. I had to look at things and go, what would this child who's in pain potentially grab and harm herself with? And so metal was kind of the top, and then plastic was the second. And after that, then kind of getting to know each child individually and understanding what the risk factors were. The other thing is staff safety, because again, what you're saying is there's kind of this double-edged sword where some of us, we become jaded after a while, we become confident, we've done the work for a while, so you kind of just relax and you go, I got this, I can handle it, and you can't do that. The only times I've ever been at risk were times when I've gotten really comfortable and thought I had it. The other piece is the emotional toll that it takes. That's also what makes you vulnerable. So if you're not processing afterwards, if you don't have an appropriate person to understand and evaluate the situation with, then you're putting yourself at risk again of not being on your A game when you're thinking of safety. So those are the top considerations.
All right, I'm gonna hear me. Yeah, I'm gonna talk about a medical setting, and I would say the top two safety considerations are in two groups, kind of medical and behavioral. So I'm going to talk about them separately, but they really have a reciprocal relationship with each other. So I think we've all been there when we're sick. I think our emotional capacity to deal with stress goes down, behaviors, moodiness goes up, and then we kind of capture that tenfold when people have injuries or illnesses that bring them to the hospital. Medical safety concerns, I think we house the sickest of the sick members of our community, and so we really want to focus on infection control, the spreading of infections in the air, fluid surfaces around us, similar but different than, you know, the bugs you take home. You want to make sure we keep the bugs in the hospital and not on yourselves as well. The other part of medical social work goes with the behavioral safety considerations. So I work on a brain injury unit. This is not specific to brain injury, but a consideration as people get certain injuries or illnesses, cognitive deficits follow. And so sometimes people are cognitively at a risk for behavioral impairments. They might be more disinhibited, sexually inappropriate, verbally or physically aggressive with you or their loved ones or people on the care team. So those are the main safety concerns I think we see and we prevent and intervene and evaluate with in the medical setting.
Thank you. So the next question is, how do you think about safety before, during, and after? And you can answer this either generally, or you can think of a specific incident or incidents and talk about sort of what went before, during, and after.
Break that down one more time.
Yeah, absolutely. So how do you think about safety in that sort of framework of before, during, and after, so that you're planning, intervening, and then monitoring or evaluating after?
Just to briefly speak about the before piece, when in doing in-home work and in the staff that I supervise, one of the things that I talk about is getting yourself familiar with the locations or with what you need to know about the home you're going to visit. And I used to be embarrassed, and I had never told my supervisors before, but I have a bad sense of direction. So on a Saturday, I'd get my map out and go roll around to the houses that I was going to have to visit throughout the week, so I at least knew what was going on. Because again, you're not on your A game when you're late and you're riding around the block, and then you can't parallel park, and then you're running it, you know what I mean? You run in the house, and now your whole plan is gone. So taking the extra time, even if it's unpaid, to pay attention and get yourself familiar with the layout of the land is one of the first things that I would recommend. And then really understanding what you can about the client and their family history and what you believe their triggers may be. As well as in the residential setting, one of the biggest thing was patterns, really understanding and noticing the escalation patterns of the kids and who feeds off of who. Relationships are everything too, because you can be fine, but when that other person steps into the room or when they have that interaction or it's group therapy and we've disclosed and everyone's kind of coming down, noticing where those triggers are was also important. So the work beforehand, just knowing the layout of the land and the community, and then also the layout of your clients and their history, that was really important for preparation.
Great. I'll talk about the medical and behavioral pieces differently. I think for medical safety considerations, prevention is more heavily focused on in the hospital setting. So we want to make sure that we are reading policies. We know how to manage certain isolation precautions. So if patient has X infection, we know that we are doing safe hand hygiene when we're going into the room. If they have a different infection, we know we have to put a gown on and a mask on to go talk to that patient. Reviewing the chart is helpful. You know, they don't make it hard to find out what type of infections a patient has, but reviewing the medical status of the patient before you go in and intervene with patient and family is helpful. Talking to the care team, being a part of that interdisciplinary plan of care, so you know if there's changes in status before you go talk to them. Intervention is the simple thing of you're putting the gown on, you're doing the hygiene, you're following up with changes and changing how you intervene based on their medical status. And then I would say the evaluation piece comes in, you know, partnering with occupational health, community standards, Department of Health to figure out, you know, what seasons are coming, what bugs are out there, flu shots for everybody. So I kind of consider that evaluation rolling right back into prevention for whatever seasons are coming. For the behavioral considerations, I think prevention is similar. It's making sure you have a good presence on the interdisciplinary care team. You know the patient, their progression of care, the cognitive deficits they might have, and how they can process information and how that's going to impact their behaviors. You know, some patients are able to can do a little CBT with or have a behavioral modification plan, and so you can get those pieces in place ahead of time. The intervention piece, I'm sure you're all familiar with the code system, the over-dramatized code systems from the TV shows, but they're actually really helpful tools to get all the correct responders to the right place at the right time. So there are codes for medical emergencies, there's codes for if patients have eloped, if there's an active shooter, there's a behavioral code, code green, if we need kind of a show of force to de-escalate and sometimes have hands-on with the patient. The other part that comes with intervention is knowing what your role is. So my social work role to a behavioral escalation is really to support family members that are there, get them out of the way, make sure the other patients are safe, and then just processing and counseling with people who observed that. I try not to have the hands-on approach because I have other staff members in security that can support that. And then the evaluation piece is there's always a post-code huddle. So you get to talk as a care team in a safe place where you can compliment what went well, and you can call out things that you want to improve upon for next time in a safe manner, so we're all on the same page going forward to that next event.
I still remember it was paging Dr. Strong. It was 23 years ago when I was in the mental health in Missouri, and we were at the hospital, and if anything was going wrong, it was always paging Dr. Strong. I still remember that. I'm going to walk you through then like 2 or 3 scenarios. I think it's the easiest way for me to kind of make this make sense to you. One of the things we do as school social work people is we are in charge of the well child checks then that'll happen. So we'll get a call sometime before school or in the middle of the day where one of our students is home and the parent or a neighbor or someone is concerned that they might be suicidal, heard they might have a gun, heard they might have something like that. So when we get that call in, then that usually comes to one of our administrators. They get myself, and then we get our resource officer. So in the St. Paul Public Schools, all the high schools have a police officer that is in the school, which is a great thing. I know there have been a lot of weird negative press about that, but I can tell you working with them hand in hand in terms of well child checks and mental health safety checks, those people are irreplaceable for what we do. So we will go then with the officer. He will drive out. And I'll accompany, and then we have a contact person set up in the school. So we set up our different, you stay in contact with the parent, we're going out. And so then when we get to the house, the first thing we do when we get there is the police officer leads the way, again, because if the kid has that gun, then they need to be the first person through the door, not me. And that's okay. So when we get in, then what we do is we quickly kind of assess the situation. Where is the child? Who else is at the house with them? And what do they have on their person? And it usually, again, there's never been a time in all of my time of doing it that we've never run into a kid sitting there with a gun in his house. So, you know, we get those reports, but we've never run into that. So the other thing is, even if they're talking about other ways of killing, whether that's through cutting or through pills or whatever, once you get there, then the other thing that I do is we never let that kid out of our sight. If they need to go to the bathroom, I'm sorry, I'm coming right with you. Or we're going to leave the door open and I'm going to stand right outside here. Because you never know, again, we don't have time to mess with that. So, and then after that situation has been assessed, either they go to the hospital or we take them back to school, or we wait for the parent to arrive. That's kind of our follow-up. And then the officer and myself and the administration will kind of brainstorm after it's all over. That's kind of the decompression of it all and what the follow-up is with that kid. So that's that one. The other one we run into at school a lot is, again, this really aggressive de-escalating need that a kid has. So a kid's brought to your office, or you find them in the hallway and they are completely outside of their ability to regulate their emotions, their physical body end of it, screaming, yelling, throwing things, kicking things, assaulting staff. When they get put in your office, the first thing you want to kind of assess is where they are in terms of your own, whether you're worried that they're going to come out on you, right? How well do you know them? If they're kids I know really well, I'm usually not real worried about that. But we also get kids that get brought in that we don't know at all. So in that case, what we do is we make sure there's plenty of space with that kid and us. And we're on one side of the door. And typically I will stand in front of that unless I'm really worried that that kid may become overly aggressive. Then you don't want to block them out, because that's the last thing you want to do in a small office is feel like they can't get out of there. But once you've got the feeling that they're not going to try to break for it, that you still just kind of stand there so they know that this is you're their way out. And most of the time they don't mess with that, most of the time. And then it's just about how you deregulate. The other thing that we are guilty of as social workers is we try way too fast to start talking to kids, right? Which is, if anything I've learned in the last 5 years, it's this whole mindfulness practice. And if a kid is dysregulated or upset, the last thing you need to do is hear your voice. So we just have to give them space and time to come down. And that's a thing that I think is really hard, especially when you're younger, because you want to just jump in and use all these clinical skills that you've been given. No. So once that de-escalation point comes down, we get a hold of parents, we get them to where they need to be, to where they're safe, or they can even stay in the building. And then again, we will go then at the end with staff and go through kind of what happened that ramped up that kid and how we could have responded differently to hopefully not have that kid go that far out of regulation as they did.
I just wanted to follow up a little bit on the in-home piece during session or when you're out in the environment. It's a little bit different. In residential, we lean more on your end where there's trained staff. There are 3 specific holds where if the situation warrants it, you can actually use physical intervention to de-escalate a crisis. In-home and in the community, the expectation is there is no physical contact between you and the child, and that there's usually kind of a plan discussed with the parent prior to you coming out so that you're both on the same page on how you're going to handle it. The interesting thing is the kids always save their aggression up for mom and dad. It's like the skills trainer or the therapist goes out and they're kind of provocative, but then they start going after mom and dad, never the therapist, which is always interesting in most situations. However, in home, it's a little bit more of trusting your gut and then get out of the situation as soon as you can. The other thing, too, is you always just want to pay attention to where your exits are when you're going into someone's home and knowing how you can get to them the fastest. I usually choose a spot that's closest to the exit without being obvious. I'm sitting on the end of the couch. I'm sitting at the end of the table. I'm not the one in the corner, so that if I ever felt the need to get out, then I can get out quickly. One of the other things when you're doing home visiting is oftentimes you'll partner with your supervisor or another staff member, where if you're feeling a little concerned, then you text or check that I'm going in, and then they should be expecting a text or a phone call after the end of your session. So if you have a 5 to 8 p.m., then I should get a phone call from you by 8:10 or a text that lets me know that things were okay. That's another sort of check and balance system that we often use out in the community. After an incident, in residential treatment, DHS has pretty strict standards on the expectation that there are documents and paperwork that must be completed that you have to review. Oftentimes, staff members, that's where it causes the most anxiety, because the last question is, what could you have done differently? And that's where most of us, we're already beating ourselves up that the incident even happened. So then when it's time to formally write and turn into DHS what you could have done differently, it causes a lot of anxiety. But if you just accept the fact that you should always ask that question after every crisis situation, then it's not that big of a deal. And then within homework as well, I implemented, it's not required, but I personally found online through a therapeutic resource, a critical incident processing worksheet. So that the next time you and I would have supervision, we're gonna pull out that sheet and go through it and understand what might have happened and how it affected you as well. Because again, when you've been doing this for a long time, I don't know, you just keep going. And so as I've been working with newer clinicians and really understand the toll that it can take on you, that processing piece is really, really important.
Fantastic. So I think that each of you has answered the next question a little bit in bits and pieces, but what do you wish you would have known as a new social worker? Or how do new social workers keep themselves safe?
I would say the biggest thing is trust your self-awareness and your intuition and your gut. Fear can be a healthy emotion. I think it starts the conversation with your supervisor, and I think if you aren't observing what you're feeling in terms of afraid of a situation or a safety concern, that's okay. I think that just means your supervisor either has skills or has worked through those emotions previously, so that's normal. And to what Steve said earlier, I think almost in most crises, I think that mindfulness and that pause is helpful. So just stick with your basic social work skills, your active listening at the very least until people can come to help, because I think in periods of escalation, that's what's needed first.
When I thought about this question, the first thing I thought about is relationships. First of all, and you kind of spoke to this, especially if you get to know someone, a client, I don't care what's on their rap sheet, how many violent felonies they committed, what they're capable of. When you have a relationship with a person, oftentimes you can de-escalate the situation simply because you have a relationship. But the relationship isn't just about your clients. I think your colleagues and your peers, that's really important. Like, for example, in residential, that person needs to have your back. If you're going to call for backup, you need to have a decent enough relationship where you can depend on your peers, and you guys are going to have to present a united front in front of the residents. So that's also really important. The other thing to me is the relationship with the space or the community. And when I say the space, for example, when I was at Avanti, I created a relationship with the space. I wandered through the building. I went upstairs and downstairs in the dorms to get used to the space, to know what it's like to be there. What does it feel like? If I was in crisis and I had a fight or flight response, what would I do in this environment? As well as the communities. Some people, if I have a lot of clients in the north side, I'm going to get to kind of know what's going on over there. You work in East St. Paul, know what that's like. So that also it can kind of create a rapport. I think relationships are really important. The second thing I wish I would have known before this is placate your parents that you're not, especially, and I don't know if any of you have experienced this, but when you tell somebody that you're doing in-home work, they're like, you go over north, but they just got shot over north. Just remind everyone that we all receive appropriate training. Most of our agencies have policies and procedures, and that your code of ethics, the social work profession in general, there are protections, there are people that you can reach out to. There's a board of social work. If your agency and your supervisor doesn't do it, there are other resources. But the biggest thing is boundaries. At the end of the day, like I said, again, the only times I've ever been at risk are when I was not paying attention to boundaries or not paying attention to my own emotional state, because you can read your manual, you can take self-defense classes, you can take judo, but at the end of the day, your personal boundaries, self-disclosure, how you kind of manage some of those things, those are the pieces that you really need to pay attention to at the end of the day, because that's kind of where it puts you at risk, and that's something that I might wish I would have known before the experience.
I think when we talk about the one thing, we talked about when you get too comfortable a little bit, but the other thing, even if you have this amazing relationship with a kid, right, or with an adult, and they're incredibly escalated, you cannot become too confident that there's no way in hell they'll ever do anything to you, because that's not reality. So I think there is still a fine line with that. Yes, we feel confident that we can handle that, but the reality still is that if someone has broke that far from reality and is that disassociated, it is possible that it still can come back on you. So you don't want to get too cocky, I guess, that, well, they would never hurt me because I've known them for 4 years. We don't know that for a fact. In terms of ways, I think boundaries, I keep thinking about that when I read the third question about how do new social workers keep themselves safe. When I first started out, we had a thing called, we had pagers, right? Because we didn't have all the cell phone technology. And so back when I was in my young 20s, I would carry that damn thing with me everywhere and tell the high school kids, page me anytime you need, even if it's midnight or whatever, blah, 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 right? Because you have this idea that you are the only way that they're going to stay safe, or you're the only one they can talk to, which is a bunch of bullshit, if you'll pardon my language. But that's the best thing you can let go of, is you are not the answer to this. Are you one of the answers? Absolutely. You are not the answer. And so that would be my thing, is keep your boundaries. Don't give them your personal cell phone number. If the agency you're working for wants a client to have contact with you outside of your normal working hours, then tell the agency they need to provide you with some sort of phone or some way that that can happen. That's not your job to put it on your personal cell phone. And it's also okay to know that, you know, if your 5 o'clock comes and then that person goes in crisis, there are organizations throughout the Twin Cities that take care of adults and kids that are in crisis. Make sure that everybody knows what those numbers are and let them handle it. That way you all have time to go do something else, because the last thing you need to do from 5 o'clock till 10 o'clock is worry about those people, because then we're not as good if we don't then focus in on what makes us whole and what we need to do. That would be the other thing that I would tell my younger self, is do more self-care right away. We start to do it when we get in our 40s and we get really tired and our body doesn't respond as well as it should have. And then we start doing yoga. Well, you probably should have started back when you were 25. And doing all that stuff, because it's a thing that you learn and you start living that way, and that goes further with you than trying to figure it out, you know, when you're on the edge of not wanting to do it anymore. I think that's it. That's what I got. Oh, and the last one, it's okay to wait before you jump in. We're so, like, if a crisis call comes out, right, or this is crisis going on, or somebody, you know, needs to go to this house or whatever, it's better to wait and have the right backup than to go there without thinking it through. That would be my other thing, is you don't have to feel like you have to rush out there with first not walking through it with somebody else before you make the move.
We have time? Okay. Can you tell us some stories? Each of you has referenced, like, you know, the one time this happened or that happened, but can you tell us some stories of recently or earlier in your career related to safety?
So most of you, when we come out, how many of you are undergrad? Cool. And how many of you are master's level? All right. So this will mainly then, although both of you, this will apply to both. But when you first get out, I had a sociology degree, which is almost equally as worthless as a BSW. Right. In terms of, now hold on, Miriam, hold on. In terms of what all those degrees of bachelor's in social work, psychology, sociology, what that's going to allow you to do is baseline, case management, entry-level mental health work, right? We all got to do the same thing, but they're not going to trust you to be a therapist or whatever, which is fine. So a lot of what we do is we do case management, right? That's our big thing. And my first thing was for a mental health hospital in the state of Missouri, and we were the case managers. So if you've ever done case management for mental health, your job is to monitor the actively psychotic in the community and to make sure that they're not going to hurt someone or themselves. That's your baseline. And again, so this was when I was 23, right? 22. And you're out there and you've got a caseload of about 10, and these are adults that are schizoaffective, schizophrenic, and schizoaffective is the hardest one, I think. Of all my years of mental health work, schizoaffective, so who knows what schizoaffective is? Let's see if we can test your St. Kate's knowledge. Raise your hand if you want to explain it to the audience. Oh, come on. Yeah, go. Do it. Close. What's the kicker to it, though? Anyone? What's the difference between schizoaffective and schizophrenic? The big difference. Schizoaffective people don't hallucinate actively. They will see things that are real, so that car pulling up there, and they think then that that car is watching them, which makes it even trickier because everything is real, right? So this kind of delusion, I think, is the hardest one to work with, at least from my experience. And so my job it was 9 o'clock at night. I got a page from one of the guys decompensating out in rural Missouri, and I went out to check on him at 9 o'clock at night without telling anybody. And when I got there, and this guy was a Vietnam vet, and I mean, built much like myself, but maybe a little stronger. And he was out there, and he had a big bearskin over him, right? And he had no shirt on, and it was cold in Missouri. It was like, I don't know, it's like 30, which is cold for us Missourians. It's really cold. And he was out there, and he said, do you want to come see, I was trying to judge where he was and how psychotic he might be. You want to come see my raccoon traps? Well, sure, I wanted to join with the client, right? And so we're walking out there, and this guy, he's got this hatchet, right, in his hand, and I so there was when I thought I really should have called somebody first before I came out here. But it turns out, you know why he carried the hatchet, is if there was a raccoon in the raccoon trap, he could chop off the head. And that way that would kill the raccoon and he could drag the carcass in. But still, now nothing happened from that night, but if you think about the series of bad events that could have happened from that, and again, that is the rushing out and the savior role of these early 22, mid-20 people that we are. And I think, you know, and again, if I had to do over, you just got to slow down and ask other people to either come with you or even should I go out there, because then I guess my supervisor would have said, no, not unless we can get a cop to come out with you. That would have been the different scenario.
I was thinking, in my career, it's very interesting because the only time I've ever been hit in the face was by a 4-year-old boy. And I was doing, in the beginning, my baseline work, it was my job to run around Hennepin County and convince actively psychotic adults to take their medications, you know? And so, I mean, I'm telling you, I mean, I've gotten grown 45-year-old men drooling on the sidewalk in front of people serving people. Here's your Depakote. Okay. Done that. Residential, I've got girls who've cut up themselves, beat up their mom, and nothing's happened. The 4-year-old clocked me in the face. And this was after a benign half-hour play therapy session, right? So me being a 23-year-old helper, thinking I'm a new therapist, let my guard down because I already knew, you know, the kid, his affect did not match what was going on inside. He was a smiler. So I'm sitting there, and and one of the protocols is you always give them a countdown before you leave the playroom, right? 5 minutes till we leave. And I was like, yeah, we've had 20 sessions. I don't need to count down. And so we're sitting down, and I kind of get close to him, and it's like, all right, let's put the blocks away. Boom. All right, I'll put the blocks away. You can go back to class. And that one hurt. That one hurt pretty bad. And it was kind of one of those simple reminders, you know, and I had already... you know, I didn't follow the protocol, kind of like what you were trained to do, right? The things that you're already told to do and why. There is a reason. Not paying attention to the history of the client and what I knew about him, along with the fact that it was just interesting. Like I said, you know, there's been fathers who have threatened us at Avanti. I mean, I've been threatened, all these different things, but it was really a small child that actually got me. So that's my reminder. So.
Yeah. All right.
Okay, so we used to have a unit at Bethesda that was for crisis brain injury patients in the community. So it felt almost like an inpatient mental health setting. So adults were ambulatory, they were physically independent, cognitively they really couldn't make their own decisions. They had difficulties with problem solving and processing and regulating emotion and all those fun behaviors that come with it. So you know, being in the role of a social worker, I think part of it is that emotional support, but then you jump in as somebody who should be intervening, setting behavior plans, providing feedback and with that patient about how we're going to reach their goals and kind of what the barriers are going forward. And so I was working with a client who was like 6'3", and I am very short, and I wear heels, and I try to be as feisty as possible, but I also try to keep that in check. So I was meeting with this gentleman, and I think similarly, I thought I got this, I need to be firm, but you know, provide empathy, but I was doing it all, and we were setting this contract, and I missed that he was escalating or shutting down. And so then I left the situation, so I left the room, we were done with our interaction. He pushed over a table, broke off the leg of the table, and use it as a weapon, or attempted to use it as a weapon against staff as he was coming out of the room. And so, not that that behavior was uncommon, unfortunately, on that unit, but it escalated to the point where we were calling in our own security. We had to call the outside police department to come into the hospital and intervene. And so it was really a learning for me personally that I definitely talked about in supervision, but then we talked in the post-huddle about really what set those behaviors off and really triggered some self-awareness on my end about how I would have handled that differently. Yeah.
I thought of another scenario when it comes to boundaries. When I was doing work with adults with schizoaffective disorder. One of the things, there was no hard and fast rule about self-disclosure and what went on. So I took it for granted. I had a woman that I had been working with for some time, and I told her a lot about my husband and my family and a lot about my personal life and a lot about where I lived and other things, because I never thought it would come up. Well, unfortunately, I became a part of her delusional system, and she began to see myself and who she thought was my husband when we weren't there. And then she also kind of got into a situation where she was desperately trying to find where I lived and was taking the bus out to the suburbs she thought I lived. And I actually saw her at the bus stop sometimes, and and this was almost 8 years ago, and I still see her at a bus stop occasionally, sort of gazing in the distance where she thought I lived. And so it was, one of those things where, again, understanding her illness and the way that it works and the delusional system, along with the fact that the agency should have done a better job of training us on how this could affect clients and the boundaries and self-disclosure. But that, it could have ended up in a very odd, ugly, bizarre situation. I mean, I've been safe, things are safe, and it's okay, but that was that boundary reminder for sure.
Thank you all very much. I know that you may have questions for the panel. We're going to have you hold those until after. We'll do Q&A after our keynote speaker, who I'll introduce in a minute. I think I'm going to let the panelists go have a seat at a table, and then we'll ask them to come back up for questions. I think they might have chairs here, or we'll find a chair. Okay. Oh, you did? Oh. Well, musical chairs. So I want to introduce our keynote speaker, who is Paul Schnell, who is Chief of Police in Maplewood, and I'm going to let him do the rest of his intro for himself.
Yeah. All right. Thank you. I've always loved coming back here. I walked in this room and I looked out and I saw, I'm hopeful. I see, it makes me hopeful to see the number of people in here in general, the number of women, the number of folks of color here. We face some really big challenges. And I just came from some meetings in Minneapolis where we're having these conversations about the notion of how do we make community safer for people, especially around police and community relations stuff. And one of the things that I said that I encouraged is that I think one of the hopeful things for me is all of you, because I think this is what we need. We need people who can, I think, understand the complexities of the world we live in and help people find a way to navigate that and advocate on behalf of people and systems and teams, and that's what social work does. That's why I love coming here. That's why this is where my heart's at, right? So I just say that as we get into this.
Can I invite you to either use this or this? We're recording.
Okay. Oh, that's right. So I'm sorry. I'm not much of a rule follower either. I'm gonna go through quickly because I think a lot of the wisdom comes from the panel and the experiences of all of us, and I'm gonna try and lay a little bit of context for this, and then we'll kind of come back together. Wow, this is like high tech. How do I click?
Great question.
Oh, you use this, yeah. All right. So I always used to do this quote that being safe enough to have real dreams in life is the beginning of hope, and I used this when I spoke at the funeral of one of my friends who was a police officer who was killed in the line of duty, and I do it because what I think his work was about was to try and make sure that people felt safe enough so that there was a way to go. And as social workers, we know, and one of the things that we would all encourage for our clients is we know that safety becomes fundamental. If people feel unsafe and insecure at that level, we can't go anywhere. That's debilitating. And I think we know this, and yet what we stand for and what we represent in many cases is this sense of hope. So when we look at what happens, national survey, 100,000 social workers, various fields, University of Pitt found that 58% reported that they had experienced at least one type of violent incident by a client. And I think that was reflected, obviously, in what the panel was just talking about. Those most at risk were people who worked in child welfare, drug and alcohol counseling, and anybody who had kind of connections to criminal justice. When we think about social workers as it relates to this, we know that, and the last panelist, and I didn't get all the introductions here, but talked about the fact that the agency should have done better. And I think we'll speak to that, but Newell found that, in her research, found that social workers oftentimes we don't report. We're uncomfortable with reporting. We found that in many cases, agencies did not have systemic processes to allow people to talk about what they were experiencing or to share or report something that happened that caused them to feel uncomfortable. And some reported that they didn't report because they feared that it would reflect on them, right? And I'll tell you that there were times for me as both working on before I went into the cop stuff as a social worker that I felt or I experienced things that were really unsafe, and I didn't do anything about it. As a cop, there were times when I was so immensely afraid of what I was facing or what I was encountering, and never talked about that part of it. It was always about what I brought to it. How do I help? And while I think that there's not a person in this room that if you had a client come to you and say, "Look, I'm experiencing significant violence in my home. I don't know what to do." We would try and help that person navigate a way out. We would talk about the fact that reporting, telling someone, finding ways to get additional support, we would encourage that. But isn't it ironic that we find ourselves in a position where oftentimes we will be the ones to recommend that, to find that level of support that we need in order to deal with that, and yet we ourselves don't follow our own advice. And I think this is one of the things that I hope that we all think about. And whether that's through ideally your agencies have reporting mechanisms in place, but if they don't, it's talking to your advisors and or talking to each other, finding ways to get and process the really crazy experiences that you're going to have. I don't know why I hate that clicking, but it just is in there, and I really don't know how to turn it off. So what we know is that oftentimes we're talking about clients who are angry, and oftentimes they feel mistreated by the system, and the system can be us or either us in our roles or our agencies or the processes that we make, the hoops that we make people jump through. And these are sources of significant frustration for people. I mean, you all have to come here and navigate all kinds of things that hoops that you have to jump through to register and get your financial aid and all that stuff, and that's crazy. But imagine and for many cases, if your life depended upon it. And I think this is the place where oftentimes the own internal kind of systemic processes that we have can serve as really key sources of frustration. We have to look at and recognize the fact that oftentimes there are people who aren't our clients, but they may be related to the clients, they may be friends of clients, they may be the ones who feel like that the agency or you as a worker or someone who is working for them or supposed to be working better on behalf of them are not representing their needs. And you can become a source of some attention. We also know, and we have to recognize, that there are times when we need to recognize this notion of the special threat that is oftentimes caused by things that are factors like drug use. We know people, as was talked about, the patterns or histories of previous violence. Sometimes it can be unstable mental conditions. We'll talk a little bit more about that. But these are things that ultimately I think we need to be mindful of and thoughtful about and put this in the context. And probably more than anything, there's not a person in this room who hasn't been in a position where at some point in time in your life, and sometimes for many of us, it could even be more, where you felt that weird tingling or the hair on your arms or the back of your neck kind of stood up a little bit, and you said something's not right here. And what the crazy part is that we need to trust that a little bit more, right? And that's the time that we need to really kind of find that connection to reach out to utilize our advisors, to our colleagues, our coworkers, our peers, to find a place to address that. But oftentimes, and I can tell you, for me and in my line of work, there are times when we go charging in spite of that, and that's not in our best interest, nor is it in the best interest of the people we're trying to help. And I think that this is one of the things we have to be mindful of. That whole notion of buck up and let's go on in there and deal with it, that's great. But it could end up being more harmful or causing an outcome for your client that is absolutely contrary to what you want. And importantly, it could have a terrible outcome for you as well. And we need to recognize this. And learn from these experiences. I mean, that's what this is all about. When we think about this, we often know that many of the field placement sites that you are going to work in are going to be in areas that we know are stressed, right? They're neighborhoods that are stressed. They can be people who are facing profound poverty, homelessness, mental illness, a lack of connectedness, and the environments themselves can be places where because we go where the needs are greatest. That's the nature of what social workers do. We go where it's needed, and because of that, we find ourselves in these places that are tough, and yet we're there to build it up. We're there to advocate. And I think our very presence is important to that. And that's what we bring to it. And at the same time, we need to make sure that we maintain this higher level of awareness. We need to make sure we do that. And I'll be the first to tell you that, a middle-aged white guy who walks around fat, dumb, and happy, and most of the time, and I can be utterly unaware of things. I know that the benefit for me is that I'm often in environments where I'm not a target. I know that. I know that the world is different for me than it is for the majority of the people in this room, women. I mean, I know that. I know that that's a benefit that I have, an unearned benefit that I have because of the gender I have. But the bottom line is that blindness can be a blindness to the kind of being aware of things that can affect my safety. Importantly, it can be a blindness to the things that can affect other safety. And an unwillingness to look at the way in which I interact with some of the systems and processes that ultimately can exacerbate and challenge the very lives that people are trying to live and live well. We have to have a biohazards thing. You just have to. You can, if you're doing home visit kinds of things, you can be in a place where people are coming in, and you may be going into a place where they were cooking meth, or where there's all weird chemicals. These are things that I think we need to be mindful of, at least be aware of. Healthcare places are incredible things, and be thinking about what some of these potential risks are as we go to client homes. We know that some settings present higher levels of threat, but we also need to be mindful that in general, that folks with mental illness are not inherently more dangerous than the general population. And I think what ends up happening is, we hear and we see many of these kind of high-level, kind of tragic things that have happened, really big tragedies around the country, and it can influence the paradigm that we have about who represents the greatest danger. And sometimes if we can begin to adopt that paradigm, we can miss the places where real danger does exist. And so I think it's just to be mindful of and thinking about the fact that this becomes important. That from a statistical standpoint, we need to be aware of that. But recognize that some settings that you will work in do represent and pose higher risk. And you will know that. And these are things I think that are worthy of talking to your field advisor and at the agency level and even at the college level, because I think it just ends up being in a place where making sure that this stuff is top of the mind, making sure that we're making this a priority does become important. We know that there are times and certain interventions and where it can be more difficult. Things like child placement, taking child custody, interventions for various different types of drug or alcohol problems. These are places where risk can become greater. The challenge for all of us, and this is exactly the conversation we're having, like in policing in a big way. But social workers, we face this difficult job of how do we do our work in a humane and fair and open way. And yet, at the same time, make sure that we're maintaining awareness of the fact that there is very real potential threats to any of us, right? Because one of the things that we would want for our own clients is to take more of a heads-up view of the world and think about that, to be able to navigate risk and all those types of things. And so, one of the ways that we can do that for our clients is by modeling that ourselves. But not getting crazy about it. That every single single person or thing that is unusual to us or different for us doesn't represent a real threat. But at the same time, being mindful of how we feel about things and talking about that and processing that becomes important. And I'll tell you that when I look at the world of police work, which we'll talk about here in a minute as it relates to social work, one of the things that we have not done well, and it has not served us well, obviously, is we haven't talked about the impact of the things that officers experience, the craziness that they get put in the middle of, and then we wonder why we have cultures that we've created a culture, a police culture that sometimes feels like there's no way to break in, there's no way to reach across. And I think from a leadership standpoint, we own responsibility for that, in part because we have not created processes or mechanisms to allow people to talk about the really crazy things that they experience and that you will experience. We do our work where people need it most, and that's different than oftentimes is sitting in the the 16th floor at 3M. It's different. It's important that we expect every client to represent some level of threat, and yet recognize, not see every client as a representative threat, but recognize those who might be. And this is a part of kind of really understanding history, understanding how clients have historically kind of addressed with various different stressors in their lives. This is a part of really doing good intake processes. What does this stuff mean relative to the way you work with them, the way the agency works with them? This becomes really, really important. Oops, I want to go back. When we look at threat assessment, and some of this research actually comes out of work that was done by the Secret Service. The Secret Service went and looked at responses to institutional shootings, whether it was at schools or government buildings, social service agencies, hospitals, and they looked at what led up to that. What were the things? What were that we might look at and understand? And what they oftentimes found was that the most dangerous the situations and the most dangerous types of environments and even people were those that people knew there's something festering here, and as opposed to kind of minimizing some of the challenges that they faced, it got to be more and more. And because of the levels of frustration of the client, what ended up happening is the agency naturally starts to respond in such a way that we have to create processes that keep our own people safe, and that resulted in the client feeling more stressed. And ultimately, what ended up happening was that this escalation resulted in a place where there was an explosion. And so what the Secret Service talked about, whether it was in schools or whether it was in government and hospitals, is that we have to be committed to trying to look for those places in our operations that grow and create high levels of stress and tension for the clients that we serve, and do everything we can to try and minimize those. That was key. When Newell, who has done a lot of work around client social work kinds of threat and risk, we have to look at and recognize that client violence toward workers is a very real practice issue. We have to own that. We have to know that. I mean, I oftentimes talk about two people that I went to school with, and I tell this stories not because of any of the two people I went to school with were fellow social work students that came before you and me. One of them was Pam Tashik. Pam Tashik, incredible woman. She was a graduate of this program. She went on from here to do incredible work in juvenile justice. Did a lot of stuff with work, a lot of stuff with youth, a lot of things with victims of crime. And Pam Tashik was murdered by her husband. And I think it's important that we recognize that oftentimes when we think about issues of violence, that violent and where the people we're working with, we assess and look for the places in their lives that where there's risk, and sometimes we fail to look at it in our own. And it was tragic that Pam lost her life. The other person that was a classmate was Greg Gall. Greg Gall was I don't even want to say what year it was, but it was a long time ago. But Greg Gall was a social worker that graduated from this program, then went to the University of Iowa, got his master's degree. And Greg went on to work with young people in an area on behalf of a community-based organization that worked with young people who had court and criminal justice involvement. And they worked to try and help them better integrate in the community. And Greg went to this client's home, and ultimately, what happened was when Greg got there, this client ended up first robbing him and then shooting him. Now, I don't tell you these stories because I want to create these crazy levels of fear. But I think it's important that we learn. Now, I had a chance to go back and I took, in Greg's case, I went back and I pulled all the reports and the investigative stuff and the interviews that were done out of Jefferson County, Iowa. And one of the things that people talked about was that Greg was aware that things were really unstable. He knew. In fact, he told his wife that day, I'm worried that something bad has happened or is going to happen. And I think, Greg Gall had a heart that was 3 times the size of mine. But I think when we look at this and we learn from these people's service and their sacrifice, I think about that sense of I have a feeling that something bad has happened or could happen with Tyler, then
that's the time to trust that. In looking at Pam's case, Pam knew, and Pam was aware, and Pam talked to me about the fact that she believed that if things did not change, there was going to be a day that her husband would take her life. And she did everything to try and keep herself and her kids safe. But in this particular case, she agreed to meet him on this given day, and just to talk about some child stuff, and that's when it happened. So I think it's important that as we think about this, that we look at our own lives and think about the places where are we doing everything we can to recognize our own value and where we ourselves have things that we are engaged in that may impact or impair our own safety. From an agency perspective, I think Dual's research really indicated that agencies should, and as you get into this, it's hard to walk into the thing the first day and say, "Where's the safety training?" Because it doesn't always happen. But one of the things that I think field placement people bring to these environments is you bring the questions that ultimately raise these issues, and I think that there's a value in that. And then I think that there needs to be and must be, specific policies that help and support people who are victimized. And oftentimes that's not going to come from the organization or the institution. Oftentimes it's going to come from your coworkers or the people in your own life that just help you make sense of what you just experienced or how you felt. So from an agency perspective, agencies are encouraged to develop a format, to track it, to look at it. They are encouraged to think about, and I would encourage you, if you do things on your own, that you think about how do you manage risk when you go into some of these environments? How do you do that? If you're driving to your field placement, your field placement's in a tough area, or with tough clients. Have you at least given thought to how you're going to manage this? I mean, have you thought about how you're going to carry your stuff? Are you going to get out of your car and be walking on your phone and doing this like I usually do? And or are you going to be up looking up and being aware of what's going on around you? Because these are the things that we convey to other people. These are the things we convey to our clients. An awareness, a sense of feeling self-assured. We know that, and I don't say this because certainly I could walk out of here today and become a victim of a crime. I know that. But we also know that oftentimes offenders look for the people that they perceive as being of least amount of risk. And so the more we convey that sense of confidence, but preparedness, thoughtfulness. What do we have in our hand? We have our cell phone in there. Can we hit that emergency button? Do you need to? Do you feel the need to carry that whistle or that spray or whatever it is? I mean, that when you get to your car, you have your key in your hand already, so you're ready to go. Instead of having to stand there and try and dig through your pockets or whatever to find them. These are just things that ultimately, the more prepared and the more thoughtful we are, I think it brings us to our clients in a way that we've given thought to this. And I think it conveys something about the fact that we recognize this as these are important life skills. We ultimately need to also look at cooperative safety protocols with agencies, and even the panelists started to talk a little bit about that. And a lot of times that can be, maybe a mobile crisis team that operates in a given county. It could be in some hospitals and elsewhere they have emergency response teams that operate, or it could be people like the police. And I'll talk about the police because we're tough to manage. I'll explain why. The research recommends that safety should be embedded in the intake process and everything that we do in our field placements. how do we look at case assignment? Social history becomes really critical. Do we know what kind of backgrounds, what triggers our clients have, and safety should be embedded in it, not just for the workers, but for the clients. And I think if we focus more on the safety of our clients, it would actually increase the safety of us. And this is the exact conversation we're having at the policing side. If we can build stronger relationships and connection that and really truly do that, that in fact our risk of danger goes down. We know that, and yet we have to think about and recognize the realities of risk, but at the same time be sure that we're addressing and aware of the needs of that particular situation or that client. Be aggressive and vigilant about identifying and addressing institutional policies that can unintentionally contribute to client violence. This is that stuff of, we make people do this. Why do we make people do that? And because frequently what ends up happening is we make people do that because we've always made people do that. That's what happens. And yet what pisses people off the most is having to do stuff that doesn't have meaning. And this is the stuff that I think that all of us should be vigilant about, looking for ways to ultimately focus more on the relationship than on some of the hoops. And look, there's hoops in everything we do. That's part of the reality of the world, but we have to be mindful about the ways in which we do that. I'm going to talk about this in just a second. I'm going to talk a little bit about the police. So when I think about the police and working with the police, because I think some of you will deal with us, and here's my recommendation. If you end up in your agency calling in the police, when the police arrive, you need to tell them what you want them to do. Here's what happens oftentimes when you're a police officer and you respond to a school or an education a hospital setting or a clinic setting or a nonprofit setting where there's an issue, is we arrive and people will say, they're in there. And then we go in there and there's things, we walk in and all of us, there's somebody standing on one side of the room and they're screaming like bloody murder, and somebody else saying, usually it's a worker saying, just calm down. And what ends up happening is if we don't know kind of what it is you want us to do, then we will take over, because that's what we do. And that may not be in the best interest of you or your client. And so if we walk in, say to us, officer, here's what I need you to do. I need to stand there. I need you to stand right there and be eye candy, because I'm good at that. And tell me what that is. And so that, and then when you say, look, now things have gone to a place where we need you to do something, then tell me that too. I do not, you know the situation, you know the people best, and to be aware of that. And the more you can tell me, the better. And if it's something where things have gotten out of control and we just need you to get that person under control because they're a danger to themselves or somebody else here, then we'll do that too. And try to do that with as much respect and dignity as we can absolutely do that. But it becomes incumbent upon you to when you call for these resources, to tell them what it is that you want them to do. And I bring this up just because I think this is one of the things that we're trying to be much more cognizant of, is not to just come in and do what we oftentimes do. Because when we walk into a domestic situation and it's out of control, the first thing that we do is we take control. And yet when we come into your environment, that may not be the best strategy. And so this is where you can be helpful for those people, those other resources that are coming to help. I learned early. Some people I've had in class are here, and I've learned early that from experiences, and I'll just share this quick anecdote. I was a St. Paul cop, and I was called on one day to a place called Hoika House. It's no longer there. It was down right by by United Hospital, and it was a facility for folks who suffered from long-term persistent mental illnesses. And I got called there because there was a woman that was out of control. They had found a bag of weed in her room, and she was very explosive, had a history of kind of acting out physically, and could become assaultive. And I got sent on that call. And I did another car, because those are always two cops get sent on that. And I remember we got at the call, and we get there, and it was kind of like on the way, the information was she's becoming increasingly violent, and says that, you know, she's gonna fight, she's gonna make the police shoot her. It was just kind of, it was getting intense. And my partner and I got there, and I turned to him and I said, look, well, this could be, you know, a big deal, you know. And so we talked a little bit about, you know, things like taser stuff and spray and all these different things. And what about the other people that may be in the area? And we had that conversation. And before I kind of tell you what ended up happening in that call, I need to tell you a little bit about the fact that I'm an adoptive dad of a set of twins. They're 25 years old now. I got them when they were 3 months old, a boy and a girl. Really, really good kids. One of them is really, really medically involved, on a ventilator and wheelchair dependent and that kind of stuff. But just really, just a cool young guy. His sister, his sister is 25. She's finding herself. She's down in Illinois someplace, and we talk regularly. But it wasn't necessarily my path, but it was the path there. And she's doing it. She's making it. And that's good. But this particular day, we adopted these kids because they were wards of the state. Their mom's parental rights were terminated, and their mom suffered from chronic and persistent mental illness. And so we got to Hoika House, and we were walking down the hall. We walked in the door, and as soon as we walked in the door, we could hear the yelling. It was just, she was wild. And we walked down the hall, and we turned the corner, and there was a nurse, and it was one of the workers that were in there trying to get her to calm down. And I looked at, and I turned, and I said to my partner, "That is my adoptive kid's biological mom." And I think about this story often because, let me ask you this question. Did it change the way we dealt with her? Do you think that the fact that she was my kid's biological mom would change the way we dealt with her? You think so? It did. We treated her like she was my kid's biological mom. And I think sometimes what can happen for us is that we get into these situations, and the first thing that we do is, and whether you're a police officer, a social worker, a nurse, is we want to weigh that humanity of that person at some level. The fact that they were somebody's mom or sister or whatever it was can be lost in that moment, and for good reason, because the world shrinks when we're experiencing this stress. It shrinks. Our vision, everything kind of comes together. This is what happens in critical incidents. We know this. And so this is the time when we have to rely on each other. This is the time when we slow things down. And what was so amazing to me is I can tell you that there were times when I responded to calls just like this, and I did not treat the person like they were somebody's mom. And I mean, I have to own that. But I think for us, and I'm thankful for the recognition of that. And I think in part of it, it comes from the fact that it came from being a social worker in part. And frankly, it comes from seeing people like you who are here, despite the fact that the salaries you're going to earn when you get out are going to suck. And you're here for the right reason. And to me, that's inspiring. So I should probably finish this, and then we'll get the panel up here and do some real stuff. Send really clear, consistent messages that violence is unacceptable for solving problems to our clients, to ourselves, within our institutions. We have to be really clear about that line, that it's unacceptable. We have to actively help our clients learn nonviolent strategies to resolve these issues and problems. We have to, and we're better off. So being aware of what goes on around you, think about having an escape route in mind, create safe environment inside your office. There's people in here, this whole notion of mental preparation is something that we really push. When we go places, think about what you would do if. So in your environment, if this happened, if they said somebody came in and they have a knife or a gun or whatever it was, what would you do? Think about that. And when you think about that and how you would respond, always think about that with the outcome of you and everyone else getting out of there safely. That has to be, we have to practice for these things because it's overwhelming when we're in the middle of them. There is no time to practice when there's something actually happens. So this notion of preparation and thinking through and visioning how this would play out. If I had this happened, if this client did this, what would I do? Be aware of and observe what's going on around you. And the way you do this is can you describe what's happening and who is where and are there dogs and is there a safe place to go if you need to get out of an area? Are you looking for signs of aggression? That the clenched fist, the chin that begins to tighten. Are you looking for the things that ultimately are oftentimes pre-attack indicators? And these are things just to be aware of. And that's the time to slow down. That's the time to disengage, to step back. That's the time to utilize as much support as you can get, because this is the place where ultimately we can either sometimes stay engaged and escalate situations, or we can disengage a little bit, and that itself will de-escalate. Observe changes in vocal expressions and tone and pattern of speech. When we think about our cars, where do we park? Women in here probably do that more often than I do. I think about parking in well-lit areas because I don't want people stealing my shit. You think about parking. Many women do think about it because there can be risk, and so this is the difference in the world we live in. If you can have people walk with you, when parking, make sure that you leave yourself a place that you can get out, change lanes or direction if something doesn't look right. Know the layout of the office. It's one of the things I hope that when you get it there, you kind of know where everything is, how to get in and out. Everybody hates the drills that we have to do. We always hate them, but they're important. Examine your cubicle. Can you quickly get out? Are you blocked in? Are they in front of the door? Are there possible threats? Did the letter opener that you got from your grandma from Things Remembered that says congratulations on your high school graduation, is that sitting in the desk and that could be used as a weapon if somebody did ultimately decide to do something? I mean, these are just things that we need to be mindful of. When we are on home visit, where do you place yourself relative to the door? Sometimes you can walk in and sit down in some of these couches and stuff, and when you sit on the couch, like your butt's like on the ground and your knees are like way up here, and so it's hard. It would be hard to get up if things really got out of control. And it may not even be your client. It may be somebody else from the neighborhood. It may be a neighbor. It could be anything. So be mindful of that, and know that when we think about weapon accessibility, I'm not just talking about guns here. I'm talking about things like, if you're in the kitchen and things are really heated and intense, that may not be the best place to be. Move to the living room. Move to a place where there's less access to things that are more lethal. Do not enter if you think that things feel unsafe or that there may be danger or threats. Know that guns are frequently kept in bedrooms or kitchens, sometimes behind the door. I talked about that already. The couches and chairs. I'm just quickly buzzing through this. Develop and understand when and how to use the police. We've talked about that in the relationships. We've and then this just is that whole notion of what does your body language tell other people? What does your tone communicate? Vocal tone communicate? Does your manner create safety concerns? Are you a person who is aware? Aware of the things that are going on with your clients, aware of the things that are going on with you, aware of the things that are going on in the environment? Those become really, really important. I talked about most of these already. Sometimes in and out boards can be a problem because it reveals where and when people are in and out, as if you're the last one there. Think about carrying spare keys. Have it in your hand as you approach the car to get in. And I talked about this already. We know that the speed of perception is affected by our attention to the lack of detail to things going on around us. So we're going to be far more acutely attuned to what's happening with our clients and what's happening in the environment. The more we put ourselves be really present in the moment. And then ultimately, mental awareness and preparation. This is how by walking through these things, we create and contribute to success. And it's the very kinds of things that sometimes therapeutically we do. We have people envision, what their life would be if some circumstances were changed or different. We've talked about this, walking through, paying attention to these things, and using these scenarios that you're thinking through as crisis rehearsal. These were some of the quotes after Greg Gall was killed. Greg Gall's death is a reminder of what social workers face and how important they are. And I think at the end of the day, we always go back to this guiding belief of being safe enough to have real wishes in life is the beginning of hope. And I want to make two little comments here. One is that I really think about and the way that safety applies to the lives of your clients and to you and to all of us. Think about the kid who's bullied in school and how the lack of safety for that kid who was bullied ultimately affects their educational outcomes, their school attendance, all these different things. And so safety is critical and elemental. And then I have two kind of unrelated, kind of shameless plugs. One, is that I do a class here, Anatomy of Violence, so check that out in the spring. You have to, right? You just have to do it. I had to, it's shameless, I know. But the second thing is I would really, this is going to sound weird, but I would really encourage you to think about, could you be a police officer? Because, and I'm saying this as a challenge. You are what we need. And we fish in a lot of different ponds to try and get people to come to this work. But I've been talking to people here about the fact that I really wish that the things that social workers have and bring and represent are the very things, that's what 90% of the job is. That's the reality. 90% of what a cop does on any given day is advocate for people and systems and try and help people realize some sense of wholeness after having something terrible happen to them, or trying to find some justice, whatever that looks like. And I recognize that we have contributed in many respects to some of the injustices that exist. But if you want to make the change to do that, we need people like you. So I say that as a challenge because maybe not today, maybe not tomorrow, maybe it's next year, next month, a couple of years from now, but we need people like you. So with that, I'm going to bring it back to ultimately to the panel up here, and let's do some real stuff.